Heavy workload. Hardly any private life. Lots of responsibility. Always pushed to the limit. Whenever I ask doctors and nurses why they take all of that on, they often say, because what I do has meaning. Meaning for the lives of others, and therefore for my own life as well. As a global forum for medical specialists, we asked ourselves, how can we most effectively support the work, ambition, and dedication of these individuals? We sought out dialogue. We listened, and we understood. With a supportive exchange among medical professionals who network their knowledge around the globe, so that they maintain their expertise at the highest level for their entire lives. With disciplinary approaches that promote specialization without losing the perspective on medicine as a whole. With smart, modular concepts that are compatible with the busy lives of medical practitioners and nurses. With offerings whose contents provide answers for the reality of everyday medical life. With a growing perspective on trends that enables medical practitioners to already prepare for future challenges today. In close dialogue with renowned specialist companies that bear testimony to the quality of the offers. With inspiring forms of learning that don't just convey knowledge, but make it an experience for the senses. And with innovative teaching methods that prepare you not just for tests, but for life. Nurses and care assistants, physicians and hospital managers, and the people who work in the home healthcare services sector. All of those who teach and learn at the YAP Academy share a passion for excellent medicine and very high personal standards. We invite you to join in a dialogue about health and medical care. A dialogue that is dedicated to life.
Sharing knowledge, learning something new, gaining confidence, thinking medicine, improving health. This is what drives people at YAP Academies all around the world. And this is why we communicate with one another in a dialogue that is dedicated to life.
All around the world, both speakers and participants, as well as researchers and practitioners meet at YAP Academies in order to think medicine further ahead. Is there anything more valuable than a dialogue dedicated to life?
The YAP Academy connects people who want to know more, to improve medical care. They are looking for a dialogue. We offer a dialogue dedicated to life.
Dialogue dedicated to life.
对话致力于生命健康。
Diálogo dedicado a la vida.
Dialog посвященный жизни.
Dialog dedikasi bagi kehidupan.
Dialog dedykowany życiu.
Dialogue dedicated to life.
الحوار مكرسة للحياة.
Diálogo dedicado à vida.
Dialog pro život.
Become part of this international interdisciplinary dialogue at YAP Academies all around the world. A dialogue dedicated to life.
Welcome to Pain Institute of Indonesia. My name is Nadia. On behalf of the organizing committee, we would like to extend our thank you for everyone who have joined in this digital dialogue of Interventional Pain Update Series 7. We will also like to greet everyone who have followed us from episode 1 and thank you for joining us. We honor to have with us today our guest expert live from America, Dr. Andrea Trescot, MD. Today's webinar is brought to you by Pain Institute of Indonesia and supporting organizer by YAP Academy, a B. Brown company. We would like to convey important messages and a guideline. Please note that your microphone is mute throughout the session. Please post your question in the Q&A section anytime throughout the session, and this session will be also recorded. For today's agenda, first of all, welcome and guidelines. After this, there is opening remarks by Pain Institute of Indonesia, and after that, we will start ultrasound in diagnosis and treatment of peripheral nerve entrapment by Dr. Andrea Trescot, MD. We also have question answer with panel discussion and then closing remarks. Okay, faculty of today, Dr. Andrea Trescot, MD. Good morning, Dr. Andrea. How are you?
I am doing well. Thank you so much for the invitation. And thank you, Yossi, for putting together such a fine program.
Okay, great. And without further ado, ladies and gentlemen, please welcome our moderator of Yossi Asmara Pen Talk, Dr. Yossi Asmara. Please, Dr. Yossi, the time is yours.
Okay, thank you, Nadia. Thank you, Dr. Trescot, for coming here. Thank you for all the participants for joining our YAP Talk, Yossi Asmara Pen Talk free webinar. This is the 7th episode. Today we have 570 registered participants from totally 49 different countries. This is very good for us. And this webinar is actually a collaboration between Pain Institute of Indonesia and also with Escolab Academy B. Brown. We already collaborate about 3 years now. Usually before the pandemic, we held a series of ultrasound interventional pain workshop with live demo and cadaver before this COVID-19 pandemic. Okay, before we start, my team and me is from Pain Institute of Indonesia and Escolab Academy want to thank you and appreciate to all the participants that help us to improve this free webinar program by giving a donation. Thank you so much. Thank you so much for all your donation. And also I will inform you for all participants, all this YAP Talk webinar will be recorded and everybody can watch it on Pain Institute Indonesia YouTube channel. So please subscribe it and share it our YouTube channel. Okay, today we have a very special speaker, a very famous pain physician, one of the best pain intervention teacher in the world, Dr. Andrea Trescot, MD, DABIPP, FIPP, CIPS. She will share about ultrasound in diagnosis and treatment of peripheral nerve entrapment. Hello, Dr. Trescot. Good morning.
Good morning, Yoshi. Thank you. Good afternoon to you.
Yeah. Okay. We are also have Prof. Sudhir here as a panelist, and also Dr. Ana Carolina from Brazil, I think. So all the panelists will join us in the Q&A and discussion after the presentation of Dr. Trescot. Okay, before we start, I will read Dr. Trescot's CV. This is a long CV. I have to read 40 part of CV, so I will try to make it shorter, Dr. Trescot. Dr. Andrea is a board-certified interventional pain physician and director of the Pain and Headache Center in Alaska. She is a past president of the American Society of Interventional Pain Physicians. Her distinguished resume include directorship of pain fellows at the University of Washington School of Medicine and at the University of Florida in Gainesville. Previous to the world-renowned leadership roles, Dr. Trescot practiced for 10 years as an interventional pain physician in Orange Park, Florida. She graduated from the Medical University of South Carolina in Charleston, got a fellowship in pediatric anesthesia at the National Children's Hospital in Washington, Dr. Trescot has authored various publications in the field of the interventional pain management and published many books about pain management. One of the most popular books is the Peripheral Nerve Entrapment. I have that book, Dr. Trescot. I hope someday if you come to Indonesia, you have to sign my book.
I would be glad to.
Okay, so let's start the presentation. So please, Dr. Trescot, the time is yours now.
All right. Well, thank you so very much for that lovely introduction. I'm going to share my screen here just a second and see if we can't get this started. There we go. All right, so we're talking about the ultrasound of peripheral nerves and its role in entrapment therapies. And so, as you just heard, I'm a lot of formers. I'm going to start with a definition of entrapment. It is defined as a pressure-induced injury to a peripheral nerve in a segment of its course due to anatomic structures or pathologic processes. And the, one second. Why is that not? There we go. And so actually back in the 50s, Kopel and Thompson stated that peripheral nerve entrapments occur at anatomic sites where the nerve changes direction to enter a fibrous or a osteofibrous tunnel, or where the nerve passes over a fibrous or a muscular band. It occurs at these sites because of mechanically induced irritation that's most likely to occur at these sites. So when a nerve makes a curve, or when it's starting to go over an area, over a hill, through a narrowed area, you can imagine that if you had a ring and your finger, and the ring was the nerve and the finger was the canal, if that ring is a little tight, then the harder you try and pull it off, the more swollen the finger gets. So these nerve entrapments can get entrapped at tunnels, at narrow anatomic spaces, fibrous bands or scar tissue, masses, bony calluses, external compression like a cast or a brace, because of edema. And we see this a lot with injury. The injury causes an edema which traps the nerve, which leads to more pain and edema, and then inflammation. And so this pathophysiology, we know that the prolonged compression of the nerve causes ischemia, and that ischemia causes pain. And it's because there's a compression of the vasa nervorum, that network of blood flow that is on the nerve itself. And there's a mechanical deformation of the myelin sheath, and that prevents the axons from actually being able to deliver nutrients down the nerve from the spinal column out to the periphery. Now that's why you're much more likely to have problems distally, because they already have decreased blood flow. You're much more likely to have problems in diabetics, in people with peripheral vascular disease, because they've already got an impairment of this vasa nervorum, with the blood vessels clogged with either cholesterol or proteins from the elevated blood sugars. Peripheral nerve entrapments can occur from the top of the head to the toes. And knowing the cause of the pain can help the physician treat the problem effectively and will decrease unnecessary and potentially worsening surgeries and therapies. And so a knowledgeable pain physician, and I hope to make all of you knowledgeable pain physicians, can diagnose and treat these nerves in the most effective manner. One thought we need to talk about before we move much further is one that's called a double crush. As I said, because the nutrients are coming from the spinal cord, if there is a narrowing or a partial compression of the nerve proximally, and then another compression distally, the two of those actually make more of a problem than either of them by themselves. And this is what we say, 1 + 1 = 3, or as the Europeans would do, 3. And so that double crush leads to more problems. And that's why you'll often see somebody with a foraminal narrowing and then an entrapment of a nerve distal, and they'll have much more in the way of problems than you might expect from that lesion in the first place. So what we're going to do here is we're going to sort of go from the head to the foot, just picking out a couple of the nerves where ultrasound can help us not only make the diagnosis, but help us identify the nerve and potentially treat it. So when we look at the occipital nerve pattern, we remember that there are multiple nerves here in the back of the head, and that there can be quite an overlap of patterns from the greater occipital nerve, the lesser occipital nerve, the third occipital nerve, as well as cervical facets, and the special case of the atlantoaxial and the atlanto-occipital joints, and also the ligaments in the cervical region, and the muscles, the suboccipital and the trapezius splenius muscles as well. The most common entrapment is that of the greater occipital nerve, and the greater occipital nerve will get trapped at several locations. The most commonly recognized is at the very base of the skull, as it pierces through a sling made up of a combination of the trapezius muscle and the splenius. And the nerve and its joining artery go through this area. And so anything that's causing spasm of the trapezius muscle will end up entrapping the occipital nerve. And since it has an artery with it, you'll get a throbbing unilateral headache associated with phonophobia, and nausea and emesis, which meets all the International Headache Society criteria for a migraine, but it is coming from outside the skull instead of inside the skull. Unfortunately, because the artery that's wrapping around the nerve will respond temporarily to triptans, these patients will get some relief from the standard headache medicines, the standard inside the skull headache medicines, and therefore carry forward their diagnosis of a migraine. And this is where most people are doing their occipital nerve blocks if they're treating it. There are, however, other places of entrapment, and the most common one that I find is as the nerve comes out through the C2 foramen, and here is the C2 ganglion. It comes underneath the inferior oblique and then travels over it. It starts laterally and moves medially, travels up the back of the head, and it's at this point where it joins in with the occipital artery to then go up the back of the head. So pathology at C2-3, flexion extension injuries can all cause problems at this level. Unfortunately, you have the vertebral artery running right here, and so this is not a procedure that's safe to do under fluoroscopy or, heavens worse, landmark guided or blindly. But under ultrasound, we can actually see this nerve, but it requires a special orientation to be able to see the nerve on the top of the inferior oblique. So what you would do is you would take your probe, start either down and move up, or start at the base of the skull and move down, looking for that first spinous process. The spinous process of C2 is the first one you see. It's bifid, and then you move laterally and put the head of the probe trying to, in the direction of the transverse process of C1. So we're going to go back, and we're not going to be able to go back. Maybe we can go back to look at the image again. So we want to be parallel to the inferior oblique. So starting out in a midline, seeing the bifid spinous process. It's not always bifid, but it's the first spinous process. And then moving the probe laterally and then tilting up to the C1 transverse process. So just to show it again, coming down. I like to come down because I can see the occiput and then that first spinous process, and then move laterally and then tilt or slide at an angle so that you're paralleling the C1 or putting the head of the probe over the C1 transverse process or in that direction. So you see the spinous process here, and as you can see, this doesn't look very bifid, but then you're going to move laterally, and as you start to tilt, you begin to see the inferior oblique as a series of muscle fibers that are very straight and parallel, and then the occipital nerve is going to be on top of that. Now I'm going to show you this and I'm going to do it slow. This is, let's see if I can get it to play. I'm going to play it once very fast, and it's very hard to see there, but we're going to do it now bit by bit. And I want you to just notice this little hypoechoic area right here on top of the inferior oblique. This is a video from my dear friend Agi Stogica. And what she did, it just showed that you can go back and forth, watching that nerve move medially as you move cephalad, and then it moves back laterally as you go more caudad. So a good idea, just to make sure you have the right target, you can watch that nerve going back and forth across the top of the inferior oblique. Your injection, there are several approaches. I actually think the safest is to come from medial to lateral. Your vertebral artery is going to be laterally here, way out of the way. You're staying on top of the inferior oblique. That gives you a nice in-plane approach. You can do a cryoneuroablation from this approach. For the stimulator, though, we're actually usually coming from below and heading cephalad. And this one, the spinal cord, the peripheral nerve stimulator is usually best done under fluoroscopy. And there you see it just one more time. The suprascapular nerve is a nerve that causes pain over the distal shoulder, the scapula, and the proximal forearm. It will often get misdiagnosed as a cervical radiculopathy. The nerve has two areas of entrapment. It gets entrapped at the suprascapular notch, but there is a second entrapment that can occur at the sphenoglenoid notch. And so two places, and either of them or both of them can be entrapped. Usually you'll see the sphenoglenoid affected by cysts from the glenohumeral joint, where the suprascapular notch may be irritated by calcification of the ligament. You see that the nerve usually goes through the notch and the artery and vein over it. As this notch gets narrower or it gets calcified, it gets very likely to be entrapped. This nerve gives the primary innervation of the shoulder joint. And so for people with osteoarthritis or a variety of shoulder pathologies, rotator cuff tears, inadequately or ineffectively, patients who are still having pain after rotator cuff repairs, this can be a very effective treatment. And so here you see the MRI, the humerus in the humerogleneal joint. Here's your AC joint, the clavicle, and here is the top of the scapula and the nerve coming through the suprascapular notch. Then coming down, and you can actually see the nerve going through the sphenoglenoid notch. So one of the problems is that the way we're teaching the suprascapular nerve localization, I think, may actually be wrong. So taught to do the probe perpendicular. So you're looking down on the sphenoglenoid notch when your probe is facing down. So to do the suprascapular notch, you have to drop the angle so that you're actually looking through this notch. So the sphenoglenoid will be more lateral and the suprascapular notch will be more medial. You'll also see that the suprascapular tends to be more V-shaped and the sphenoglenoid will tend to be more U-shaped. And the consequences of that are that most of the nerves that go to the shoulder joint itself come off early as the nerve passes through its notch, the suprascapular notch. So if you're injecting at the sphenoglenoid, you may not be getting as much effect to the shoulder joint as you might have expected. And here you see the nerve and the artery lying above the suprascapular ligament, supraspinatus, under the supraspinatus muscle and under the trapezius. So the ilioinguinal and iliohypogastric nerves, there's a wide overlap of nerves in this groin region with the genitofemoral, the ilioinguinal, and the iliohypogastric nerves all in a reciprocal fashion innervating this area. So if the ilioinguinal is large, the iliohypogastric is usually small. You may have no genitofemoral stimulation in the genital region and all of it from the ilioinguinal, or you may have all of it from the genitofemoral and none of it from the ilioinguinal, or an overlap of those. And that's one of the problems that we see when we're assuming that the ilioinguinal nerve is causing the groin pain. So these ilioinguinal and iliohypogastric nerves are branches of T12, L1, L2. They come across the iliac crest. They can be entrapped at the edge of the external oblique, and then they come across the abdomen and can go on to the pubic region, or can stop at the edge of the inguinal ligament. And here you see the ilioinguinal and the iliohypogastric. You see where they can get entrapped. This is the portion of the external oblique. They then come around the front, and they're not shown here, though you can see part of it coming across the ilioinguinal ligament here. And here you see the genitofemoral nerve branching into its genital branch and its femoral branch going on down into the groin. So the coming around here, you can imagine that if you're doing a hernia repair, that this nerve can be traumatized. And when they're doing mesh treatment of the hernia, they have to take a great big bite of this region. And so that puts both the genitofemoral and the genital branch of the ilioinguinal nerve at risk. So remember that when you have your patients with groin pain after inguinal surgeries. So for ultrasound, you're going to find the ASIS as your landmark. Here's your ilioinguinal. And so you'll see the ASIS shadow here, and then the external oblique, the internal oblique, and the transversalis muscle, and the iliohypogastric and the ilioinguinal lying in the levels between the two middle layers. Just remember that the entrapment, though, can be proximal at the external oblique, or it can be distal at the rectus border, which we'll talk about in a minute. And so here you'll see again a lovely picture that Aggie did, looking at the nerves as you go up and down, looking at them moving in the layer between the external oblique and the transversalis, the internal oblique. Now, I really love talking about the anterior cutaneous nerve entrapment, because this is a problem that gets misdiagnosed so many times. I had a patient just last week who had had a mega workup, and the problem was the anterior cutaneous nerve entrapment, or an acne syndrome, or acnes as it's sometimes called. And you have to be careful, because if you try and look up acne, obviously all you get is facial sorts of things. So it's not a well recognized, but it's a very, very important cause of abdominal pain. And based on which nerves are entrapped, it can really give pain like a gallbladder, like a spleen, like an appendix, like a diverticulum, like a interstitial cystitis. It can be the great mimicker. And I had one gal who had 8 laparoscopies for what was considered or diagnosed as endometriosis. they had completely taken out all the endometrial implants that they could find, and she still had pelvic pain. She would get 2 weeks of relief after the surgery, and then it would come right back. And it appears that the problem is, again, these the thoracoabdominal, or as a special case, the ilioinguinal nerves that come from the spine, come around and get trapped at the edge of the rectus border as they pierce the rectus border to supply blood and nerve impulses to the rectus abdominis muscle packness, to that six-pack. And here you see a dissection we did where you can see the nerves and arteries going through the sheath. I've taken the sheath off here so you can see the rectus muscle, or actually a wonderful anatomist, Gabor Bazo, who in Budapest, who did these dissections with us. And so you can see that there are very specific areas where these nerves enter, and there'll be a little break in the fascia, a little half-moon defect in the fascia where those nerves are piercing through. And so here, just to show you now, this patient was actually laying supine, but I've tilted it up so you can see a little bit. So you feel just along the edge of the rectus, and you can feel just a little spot where a defect in the rectus, and you'll find it at the level of the umbilicus is the most common, but you'll also find ones a couple of finger breadths above and below that area. And so if you have the patient tighten up their stomach muscles, then you're not feeling, and they're still tender there, they're not feeling the deep structures. They're only feeling the abdominal wall, because I can't reach into the belly when those muscles are tight. And so that's called a Carnett sign, and that will help make a distinction between an intra-abdominal and a abdominal wall problem. So with the ultrasound probe, it's very easy. You're going to see the rectus very clearly as you put the probe on the skin, and then all you do is move laterally as you start to see the rectus narrowing down, and then it'll join in with the external oblique. But it's right where it narrows where we'll see the blood vessels and nerves coming in. And so here you see the rectus abdominis, what's called the double layer, double sign. This is the peritoneal pleura, the peritoneum, the parietal peritoneum here, and then the actual gut, and you can often see the gut moving along here. And then, so this is the rectus, the linea alba would be here to the left. And as you move the probe laterally, you'll see the narrowing as the rectus starts to narrow down, and then it comes to an area where you can find the blood vessels and the nerves. You can't always see those, and but there can be, you can always always know that it's going to be just at the edge of that rectus border. Always going to be there at the edge of the rectus border. So the lateral femoral cutaneous nerve, neuralgia paresthetica. I see this happening all the time, and it gets misdiagnosed all the time as a radiculopathy, as a variety of things. The patients will have an anterior lateral thigh pain. And again, the lateral femoral cutaneous nerve is a branch of the lumbar plexus. It comes out through the psoas muscle, underneath or through the inguinal ligament, over or through the sartorius muscle, to then innervate the anterior lateral aspect of the thigh, sometimes giving a branch over to the greater trochanter. And here you see it on MRI. Here's the rectus femoris, the tensor fasciae lata, and the sartorius. And these are going to be our landmarks as we're looking at the nerve. The most common thing we see, this is when people either during pregnancies or they've gained weight and the abdominal wall starts to sag and the nerve gets trapped and stretched as it goes over the pubic rim. We'll also see this with people who are wearing holsters, so COPs will do this a lot. Seatbelt injuries, we'll see it from car accidents. And any people who wear big wide belts will also see this as a problem. And so our landmarks are the sartorius, the rectus femoris, and the tensor fasciae lata. And you'll see the nerve in sort of what's been described as a cat's eye area, a hypoechoic area surrounding the nerve. Based on where you're actually doing the probing, you'll see the sartorius as either relatively small or relatively large, and either next to the tensor fasciae lata or over and next to the rectus femoris. And so what we're seeing here is you see the nerve, the sartorius, and the sartorius has a very distinct shape to it. And then the rectus femoris, just lateral to that. And so there's the nerve in its capsule, basically. And so just to show it again, there's the nerve, the sartorius, and then the rectus femoris. And then the tensor fasciae lata will be more to the right. The infrapatellar saphenous nerve, again, one of my really favorite nerves. This is a branch of the saphenous nerve. It will give pain in the medial aspect of the knee, but it can go all the way around to the lateral aspect of the knee, and will also give pain going down the leg, and can go all the way down to the foot as the branch of the sartorius. As you know, there are multiple nerves that go to the knee, 10 actually, but the infrapatellar saphenous, in my experience, has been the most common, and it is a very, very common cause of pain, either from a knee surgery, including arthroscopies, ACL repairs, tibial nailing, and total knee replacements. And in fact, just about every total knee replacement patient that I've seen who had pain and dysfunction of the knee postoperatively had this infrapatellar saphenous nerve as a problem. It comes under or through or behind the sartorius muscle, but it comes onto the anterior aspect of the knee at the level of the flare of the tibia. So those of you who are doing superior medial and lateral, as well as inferior medial genicular nerves, do realize that there is no such thing as the genicular nerves. If you look at an anatomy book, they all have names. This one happens to be the infrapatellar saphenous nerve. And as I said, I no longer do the superiors unless the infrapatellar saphenous, or IPS, has not given relief. Now you can do this landmark guided, you can do it fluoroscopically guided, but the problem is that the nerve can have a very variable location, as you see here. And so in my mind, ultrasound is the best for doing this. And to find it, it's one of the absolute simplest nerves I've ever seen to find. And I am going to encourage you, if you've never done ultrasound before, start with this nerve. And so what you're going to do is place the probe on the just medial to the ridge of the tibial ridge, and then move cephalad until you start to see the flare, and then move just a little bit medially, and then you're going to tilt back and forth to be able to see the nerve as it's wrapping around from medial, where it's with the saphenous nerve, and then it wraps around, so it'll be coming underneath your probe in a short axis view. And so to show you this white line here is the tibia. Nice landmark. It's a nice straight line. The further down you start, the straighter that line is. And then as you start to move cephalad, you'll start to see the dip, the flare. And then as you just move medially, you'll see the nerve coming up into view. There may be one nerve, there may be several, there may be vessels next to it. I've seen often for the post-surgical knees, I've seen varicosities around the nerve. And so you can do a little bit of hydrodissection, release the scar that's entrapping the vessel, and then the blood vessels just disappear, sort of like taking a tourniquet off, and then the blood vessel goes down. Do recognize though that you'll often see the nerve outside the boundaries, above or more commonly above, occasionally below, at the bottom part of the flare. And so this may well be where your RF treatments don't work if you're placing them anatomically, because the nerve may not be where you think it is. But under ultrasound, the injection becomes a very easy in-plane approach. You can do a hydrodissection around the nerve. And this is the nerve that my staff calls the Lourdes nerve. And they say that because the patients will come in on wheelchairs and crutches and canes. And after the injection, and often it's just a landmark guided injection in the office, they'll go, oh my goodness, they're bending their knee and say, could it be working that quickly? And I say, well, it's the local anesthetic. I don't know how long that's going to last, but yep, I think we've made the diagnosis. And they head out to make their follow-up appointment. And the staff is going, Mr. Smith, you forgot your cane. I literally have a pile of canes and crutches in my office after having done just this one nerve. And so I'm the chief medical officer of a implantable stimulator company, both spinal cord stimulation and peripheral nerve stimulation. And this is the first study we're going to do because you can just thread the stimulator just right under direct vision, right over that nerve. And you can pick up then, because it has multiple electrodes, you can pick up multiple nerves if there's several in the area. And the doctors who are using this technique right now have had just remarkable success with this. So we're really looking forward to this randomized, double-blinded, sham-controlled trial. So we'll be doing doing the diagnostic injection, and if they get relief, they get a temporary trial. And if they get relief from the trial, they then get implanted. And at that time, they get randomized to either an active stimulation or a sham stimulation. And we're doing these as a subthreshold stimulation, so the patients won't be able to tell which is which. So we hope to start that study in the within the next 2 months, we hope. And then the last nerve I'm going to talk about is the posterior tibial nerve. This is a nerve that controls the pain going to the heel, the arch, and the ball of the foot, and all the way out to the toes. It is a pain that tends to be along the medial aspect of the foot and arch, but it can be the whole bottom of the foot, primarily though medial more than lateral. And that's because the posterior tibial nerve will be passing through the tarsal tunnel, which is very similar to the carpal tunnel in that it has multiple tendons, nerves, and arteries that are going through this tunnel. The posterior tibial nerve at various locations will divide into the middle plantar nerve, medial plantar nerve, and the lateral plantar nerve, and it will give off a branch to the heel, which is the medial calcaneal nerve. In here as well, you have the artery and 2 veins. And so to find it, it's sometimes very hard to find the posterior tibial nerve as you come up higher in the leg. But since this is where the entrapment usually occurs, this is a great place to try and find it. And so we're going to be looking for the landmarks that are the vein, artery, vein that is around the nerve. Sometimes the nerve will be above this, but most of the time it'll actually be below this combination of vein, artery, vein that's located right at the level of the retinaculum. As you move more cephalad, those blood vessels move away and the nerve is a little harder to find. And so I always recommend that you find it in the tibial tunnel, in the tarsal tunnel, and then move more proximally if you're trying to trace it more proximally. And so here you see the vein, artery, vein, and the nerve sitting right in their lap. And so you'll find tendons as well. And remember that the tendons are sometimes hard to tell apart. And so make sure you're using your concepts of anisotropia to identify what is nerve and what is tendon. You can use your Doppler to actually find the blood vessels as well. So in summary, peripheral nerve entrapments can cause a variety of pain conditions, including headaches, facial and neck pain, the chest wall pain, upper extremity and lower extremity pain, abdominal pain, as well as back pain. And so nerves that you might be thinking about that we didn't talk about here would be nerves such as the dorsal scapular nerve, the intercostal nerves, the superior cluneal nerve, the middle cluneal nerve, the pudendal nerve. All of these are done at the sciatic, the nerves in the popliteal fossa, the branches of the sural, the superficial perineal, the superficial saphenous, are all nerves that are commonly problems with peripheral nerve entrapment. But if I went through all of those, we'd be here for the next 3 or 4 hours. So I wanted to give you just a smattering of types of nerves that might be causing problems. These peripheral nerve entrapments can, as I said, just a whole variety of pain problems. Some of the things that you might want to think about are things like CRPS. The patient has a trivial injury on their wrist that ends up traumatizing the superficial radial nerve. And that superficial radial nerve will then trigger injury, will trigger a neurogenic edema, which then causes swelling and pain and a release of all that sensitizing chemical soup of prostaglandins and leukotrienes and histamines that are all being released at that site of trauma. That causes more entrapment of the nerve, which leads to more problems and a very vicious cycle. Now, we've looked at doing sympathetic blocks, and in this case, you might classically look at doing a stellate ganglion block, which is great, but it doesn't treat the underlying entrapment. It may decrease the edema. By decreasing the edema, you can decrease the entrapment of the nerve and the pain, but it doesn't treat the underlying problem. And so I'm going to encourage you that based on your history and the physical exam, that you consider where the injury was actually taking place. Now, often these patients will be too hyperesthetic to actually even examine them. So one of the tricks I'm going to tell you, I do, instead of a stellate ganglion block now, though now that ultrasound is available, it's a much safer technique than it was either blindly or under even fluoro. I do instead an axillary brachial plexus injection with 10 cc's of 0.5% lidocaine. Now that's a total of 50 milligrams of lidocaine. So even if I got all of it in the blood vessel, that's not going to cause problems. But under ultrasound, I'll see the brachial plexus, I'll put in local anesthetic, and within very few minutes, all the hyperesthesia and edema are disappearing. Now I can examine, and then I can do my ultrasound, and then I can do my hydrodissection or cryoneuroablation or peripheral nerve stimulation to treat the underlying cause of the problem, rather than continuing to do time after time after time stellate ganglion blocks. So I recently had a patient who had had 40 stellate ganglion injections, and she would get 2 weeks of relief, but the pain came right back. Well, her original injury had been a IV start into the area of the wrist. So by history, it was very clear that this was a superficial radial nerve. And sure enough, when we did the technique I described, we were able to identify the nerve and do the hydrodissection, and ended up offering her cryoneuroablation and stimulation. It's a workman's comp case, so that case is still pending. In addition, we know that history and directed physical exam followed by diagnostic injections are key to the successful diagnosis and treatment of these entrapments. So when your patient says that they have this abdominal pain, ask them to point where it hurts. point with one finger, and they will almost always be able to point to where it is. The one caveat to that is that infrapatellar saphenous nerve. They will not be able to tell where that nerve is coming from. You're then able to do the diagnostic injection. Ultrasound will often show you where that pathology is, whether it's a neuroma or scar entrapment or a curve in the path. So for instance, I'm finding with median nerves, we think the median nerve entrapment occurs at the carpal tunnel. But it has been absolutely fascinating to me. Tiago, Tiago, what is your last name? I just forgot it and I apologize. Tiago's an amazing ultrasonographer in Brazil. He pointed out to me that when you look, if you trace the median nerve back more proximally, it starts anteriorly, but then it makes a dive to get down onto underneath those tendons as it comes into the forearm. And in some people, that dive is a very, very sharp dive. And what did I tell you happens? Where do nerve entrapments occur? They occur at those sharp dives. So when you're looking at your patients who've had a failed carpal tunnel surgery, think about the fact that the pathology may actually be proximal to that. So it's the idea of listening to what the patients say, have the patient point to where it's hurting, and examine that area specifically. And then you follow that by the diagnostic injections. So as Yoshi said, I wrote a book called Peripheral Nerve Entrapments, Clinical Diagnosis and Management. And in this book, I have the pictures of how the patients are coming in and presenting, the anatomy, including the drawing anatomy and the dissections, the physical exam, the differential diagnosis, the diagnostic tests, the landmark guided injections, the fluoroscopically guided injections, the ultrasound guided injections, the cryo, the surgical relief, the stimulation, and the complications for some 77 different nerves, really from the head to the toe. So this has been my life's work. However, I do not get any royalties from Springer. So if you are interested in a PDF of the book, and Yoshi, I owe you a copy of that PDF as well, I'm going to recommend email me at drtrescot@gmail.com, and I'm happy to offer you that copy. So with that, I am going to stop sharing my screen and see if we can open up for questions and potentially comments from our distinguished panelists.
Okay, thank you, Dr. Trescot, for a fantastic presentation. Very clear and so many tips for us. Actually, when you talk about the carpal tunnel and the proximal problem from carpal tunnel, okay, that makes I think something for me, because it's really happened to me that many of my patients have a surgery after surgery for carpal tunnel and still get a pain from because of it. So
you may be a hero by just tracing it more proximally and finding the entrapment.
Yes. Okay. So we have so many questions here. Okay. I invite Prof. Sudhir and also Carol. Hi.
Hi.
Hi, Carol.
Good morning.
Carol, bom dia, tudo bem?
Bom dia, Andrea. Thank you for your lecture.
How are you?
I see a lot of prolotherapy questions just coming up on the screen, and
yes,
that's one of my real passions. And I think for certainly, I've been doing prolotherapy for about 30 years, and I have a nonprofit that I set up, Project Pain Relief, to try and teach prolotherapy in the third world, because in places where patients do not have access to a total knee replacement, for instance, if they have pain and they can't work, they can't eat. And so with just a $5 bottle of dextrose 50%, you can dramatically improve the quality of life. I've actually had prolotherapy done on my thumbs, because this is what I do all day, every day. I'm either examining with my thumbs or I'm injecting with my thumbs. And so they were actually subluxing, and I had prolotherapy. And then more recently a little PRP in those areas. So I'm still able to have those thumbs of steel.
That's really good. Okay, so for the question, okay, I hope we can show our participant who give us the question. The first one is Dr. Faris. Dr. Faris is from Indonesia. Okay, Linda, can you show Dr. Faris?
Yes, it's already in, Dr. Faris.
Oh, it's already in. Okay, Dr. Faris. Yes. Hello, Dr. Faris. Hello. Hello, Dr. Faris.
You may speak.
Dr. Faris, you can ask your question directly to Dr. Trescot. Still cannot connect. Oh, okay. There's a problem, Dr. Faris, that have the microphone. Okay, so I will read the question for Dr. Trescot. What kind of ultrasound, Dr. Trescot? Dr. Faris asked, what kind of ultrasound do we have to use to properly diagnose occipital nerve entrapment? Do we have to use?
Let me go. I'm going to go off camera 1 second because I'll show you what I use.
Okay.
One second. So I actually use a portable ultrasound that it runs off an iPad. Well, not an iPad. This has to be a PC pad, and then the probe just plugs in to the side, and I have both a linear probe and a curvilinear, and they just pop off here. So it doesn't have to be as sophisticated. All you have to do is be able to see the bone and the inferior oblique, and then you'll be able to see the nerve on top of that. And so it's a very superficial structure. And so as long as you can turn down the gain enough to be able to make the distinction in the tissues of the inferior oblique, which should look very flat, the bone should be coming up like this, and just stay away from the lateral aspect, which is where the vertebral artery is.
Okay, so that's the answer. But Dr. Faris has another question, I think, Dr. Trescot. Are we able to recognize acne pain and differentiate it from other abdominal causes?
What kind of pain?
Acne.
Abdominal. The acne pain. It has to do with the physical exam. And the patients they'll be able to point to an area. And what I do is I put a little gel on the belly, especially when they're very anxious about touching the belly at all. And I put the ultrasound probe, and then I just run my finger behind the ultrasound probe, and then they'll go, oh, right there. And so you'll find the point tenderness there. They're willing to let the ultrasound probe because they've been ultrasound a bunch of times. And then I just sort of sneak my finger in behind it. The gel allows me to be able to feel that little half moon defect. And but it's just amazing, and you can feel it on yourself. So I'm going to encourage you tonight, when you lay down in bed, just find the rectus border and then just feel up and down the edge of the rectus, and you'll feel, oh, there it is right there, the little tiny paresthesia, and just a little indent in the fascia, this sort of little half moon, and there'll be a paresthesia right there. And so once you can find it on yourself, you can find it on anybody.
I will try this night.
Yeah, and it's one of those things, again, these patients will have been told that they have all sorts of intra-abdominal processes, but they do, and they've had their gallbladder taken out. I've had people had their gallbladder taken out for left upper quadrant pain. because they had a couple of stones in their gallbladder. Well, it had nothing to do with their gallbladder, and surprise, surprise, the pain didn't get better when they had the gallbladder taken out. So this is something that for family practitioners, the primary care doctors, to recognize early. Instead of sending the patients to multiple doctors, they can make the diagnosis themselves. And then send them to you to treat.
Okay, we have a question from Dr. Ninandini. Hello, Dr. Ninandini.
Hello, Dr. Asmara.
Hi, you can ask your question directly to Dr. Trescot.
Thank you very much.
Yes,
dear Dr. Trescot, thank you very much for such a wonderful presentation. My question is, I usually diagnose patients with the nerve entrapments with the local anesthetics. But then I struggle with how to proceed further because I'm from Nepal and we don't have much of an option to further give permanent treatment for such cases. So my question is, how should I proceed after a successful diagnostic injection? Whether I should try on repeated hydrodissection with dextrose, or whether I should proceed with nerve ablations. I'd like to hear from you, ma'am. Thank you.
You took the words right out of my mouth. I was going to recommend hydrodissection with 5% dextrose. It's amazing. And I think the hydrodissection has the potential for treating the underlying cause. Be careful with the neuroablative procedures. Pulsed radio frequency is reasonable, but conventional radio frequency, I'm very concerned. Cooking those nerves will end up leading to much, much worse problems. In the same way, I think if you have to do something, a low-dose phenol, a 3% phenol, may be a reasonable approach. I wouldn't use alcohol in these situations, but cryo is clearly my treatment of choice. And it is, I see people going, well, why would you use a cryo machine? They're only, what do you do with it? And I say, my goodness, all of these nerves are ones that would be candidates for cryo. And so the machines are getting more and more available. They're getting smaller, and they're even little handheld machines now that run off a nitrous cartridge. And so those are all potential options. So dear, Carolina, anything that I would recommend?
I was just going to add to, I think you are absolutely right. The thermal radio frequency is not a good idea because, you know, your patient really feels numbness for a very long time, and that numbness is more disabling than pain sometimes. So I do not recommend that. I have done
and the anesthesia dolorosa. I just saw a case of that yesterday. Friday.
Absolutely, yeah. I do pulse RF. The problem pulse RF in US is they don't pay. They still conditional. They consider it as investigational and they don't pay. So my treatment in a similar situation would be, I still like to inject steroid and normal saline, but I will change my practice slightly. What I do is I kind of use 2 cc of normal saline and 10 milligram of dexamethasone initial injection. I leave my needle there and I use another 2 cc to do extra hydrodissection. I think hydrodissection is, we have appreciated the effect of hydrodissection. If we really master hydrodissection, it will take away all the possibility of surgical decompression, because really there is very little room for surgical decompression. And then if I fail, I still don't like to do neurolysis. I then would jump to peripheral nerve stimulator, which is kind of easier and also very effective. So that's how I treat my peripheral neuralgia rather.
And by the way, Stanley Lamb just did a lovely, lovely article on hydrodissection on an open access journal. So I strongly encourage that y'all to take a look at that. Dígame, Carolina, what would you say? What would you do? Carolina, do you have anything? Do you have any suggestions?
No, I learned everything with you, so I do the same. The problem for me is that when I have post-surgery entrapment, the rate of success, it's terrible for me. Usually the pain change, but never finish it. Then I have to use the the stem, the peripheral stimulator. Yeah.
Tiago Noir. I couldn't
Yeah,
think of his
yes,
Yes.
I was trying to remember his last name too. Yeah, he's pretty. He's excellent in ultrasonography.
Excellent, and I've learned a ton from him. And so the Brazilians rock. It's
okay. So next time I will invite Tiago.
Oh, you should.
In the YAP Talk.
Well, he's very shy, but he is from a teaching point of view. He's just brilliant.
Okay, thank you.
You should invite him. Yes.
Okay, another question here from Dr. Mirza, I think. He's my friend here from Indonesia. Mirza. Hello, Mirza.
I think they must be leaving their microphone.
Yeah, okay. Sorry. Okay, this is the question from Dr. Mirza. In case of nerve edema caused by entrapment, how about the rule of steroid injection? What recommendation for the steroid?
I absolutely. Yeah, I start with steroids. I use I do depomedrol. I like the time-released aspect of it. And so I think steroids are the first-line drug for this. And you just have to be a little careful if you're doing very superficial injections to worry about hypopigmentation or skin atrophy. I'll use my biggest dose the first time, and I'll repeat it one more time with a little bit smaller dose. Sort of like putting out a fire. I want to put a big bucket of water on the fire, but if it doesn't completely go out, I don't walk away from it. I try again with another bucket. But if I don't do multiple injections of steroids, because if it didn't work the first or second time, it's not going to work after that.
Okay. We have Dr. Mirza here. Okay, Dr. Mirza, you can ask Dr. Trescot.
Yeah, Dr. Trescot, I do the fluorotherapy sometimes combining the shoulder pain. I have a patient that injury experience from the sport injury. He a tennis player and also have the infraspinatus atrophy and also shoulder pain. There will be an entrapment of the nerve of the suprascapular nerve. According to your lecture, before that we have to hydrodissect or maybe release the entrapment in the incisura scapularis knots, the scapular knots that under the ligament. But it's the nerve is a very long journey, you know, until reach the infraspinatus. So if it is the infraspinatus atrophy, we should inject in the
sphenoglenoid.
Lower, sphenoglenoid.
Yeah, the sphenoglenoid, and that it's interesting. You don't usually see the supraspinatus atrophy because it's hidden by the trapezius. So an MRI will tell you whether you actually have. If you don't have supraspinatus atrophy, then you're absolutely right. The pathology is at the sphenoglenoid. If you have atrophy of both, best seen either under ultrasound or an MRI, then you need to look at the proximal pathology. And so one of the things that you bring a good point about is that one of the other causes of nerve entrapment is instability. And there, I think, is where the prolotherapy, by stabilizing the joint, then prevents the entrapment that occurs because of the instability. So the prolotherapy is a very good, they go hand in hand or hand in glove, whichever you would think about it.
Yeah, I do the dextrose flow therapy with the 12.5% dextrose and lidocaine, maybe less than 1%, and then I do also the steroids in the suprascapular knots. Is it contrary, or maybe is it acceptable for you? What do you think?
If you're doing them both, it to me, from a mechanism point of view, the prolotherapy is trying to create an inflammation, and the steroids are trying to decrease an inflammation. And so I try not to do both of them at the same time. So I'll try and do the it depends on what I think is the underlying problem. I'll do the steroids for the suprascapular notch, for the suprascapular nerve. If that gives pain relief, but it keeps coming back, Then I'll do prolotherapy of the shoulder. And then if you've still got pain, but the shoulder is stabilized, I go back and do steroid of the nerve. So it's a little bit like tightening down the spokes of a bicycle wheel. You tighten down this one, sometimes that changes this one, and you have to work at it as a balance to be able to get the wheel balanced.
So, the interval, 3 weeks? Between the
2 to 3 weeks apart. 2 to 3 weeks apart.
2 or 3 weeks. Okay, thank you, Yossi. It's very
No, Prof.
nice.
Sudhir, maybe there's a Prof. Sudhir want to give something to say, Prof.
Yeah, Andrea, my question was, do you do prolo and hydrodissection at the same time, or?
I'll do those two because they're not competing mechanisms. So
just
I'll do
steroid.
But the steroid I won't do at the same time as the prolotherapy.
Yeah, got it. Yeah.
So you give the 5% dextrose for hydrodissection, and then after that you give the prolo dextrose, like that.
I may do those both at the same time, though in my country, I can't, they have to pay for prolotherapy out of pocket. So I'll usually just do the hydrodissection for free. Or I'll bill for the hydrodissection and then I'll do the prolotherapy for free. You know, it depends, but I have the luxury of most of my patients live locally, so they can come back easily for another procedure. But when I have people who come, I had actually patient come from the Philippines to Alaska and one that came from Hong Kong to Alaska. So for those patients, you know, we only got a little bit of time to work with them. So I do stack procedures. I do multiple procedures at the same time.
I just wanted to add one more thing. The practice in the United States is not as easy as practicing in Indonesia and Brazil.
Okay, Professor. So for the next, thank you, Mirza. Thank you, Mirza. So for the next
thank you, Prof. Sudhir. Thank you, Dr. Andrea. Thank you, Yossi.
Thank you, Mirza.
Nice to meet you all.
Yep.
So the next question is from Dr. Adel Ibrahim. Hello, Dr. Adel.
Hello.
Hello.
Salam.
Hi, Dr. Adel.
Thank you very much, Dr. Trescot, and I'm very happy to listen to you. You are very famous and well-known, talented physician.
Thank you.
It's my pleasure to attend today with you. Thank you to Asmara for organizing this committee and the colleagues. I want to ask, as you said, in the lateral femoral cutaneous nerve entrapment, it may be entrapped through the inguinal ligament, through the sartorius. So it will be the same if the same intervention at the muscles and the ligament, or sometimes through the bone. I read some papers, they said sometimes anterior superior spine. So how to release this?
You have caught me, because one of the concerns I have, and I was trying not to throw away too many standard approaches. And you know, I already was talking to you about how the standard approach to the suprascapular isn't the right one. Unfortunately, the easiest place to see the lateral femoral cutaneous nerve is distal to where the entrapment is, and you're absolutely right. And most books will show an in-plane approach, and it's very easy. But if the pathology is proximal, you really need an out-of-plane approach. And I do a hydrodissection back underneath the ligament. So very, very good pickup, and that is very true. It is not, the entrapment, you have to find where the entrapment is, and it may well be proximal to where we can see it easily.
Yeah. I had some patients that relieved for a while and returned back again, especially neuralgia parasitica. And I was about to feed up because of I know I can see very well by 18 hertz ultrasound nerve. I'm sure I'm there, but after a while it comes back again. So don't know where the entrapment is exactly. Even I'm using out of plane technique, but how many sessions should I do? Should I add steroid? I usually do use dexamethasone. Can I do withdrawal, or what's your opinion?
One thing I've played around with is a combined ultrasound fluoroscopy technique, and I've done this for carpal tunnel as well, where I do an out-of-plane technique and I inject a little bit of contrast along with the rest of my fluid. If for the carpal tunnel, if it gets into the palm, there's not an obstruction of the nerve. and it's not the carpal tunnel that's causing the problem, or the canal that's causing the problem. In the same way, I've done one patient where I did, I threaded the needle up to, in an out of plane approach as high as I could, did my hydrodissection, and then put in a little bit of contrast and saw that it didn't go underneath the inguinal ligament. So then I passed a catheter, a Rax catheter up there, and did sort of a hydrodissection that way. And that was successful for that patient. Don't know if it would work for anybody else. And I'm gonna have to take just a second and plug in my computer because it is running out of juice. So, but I'm listening, so keep talking.
Okay, Dr. Abdel?
Yes.
Okay, we will move to the another question. It's from Dr. Tushar. Dr. Tushar Munoli. Hello,
Yeah.
Dr. Tushar. Hello.
Hello. Yeah.
Hello.
Hello,
Yeah.
Dr.
Yeah. Excellent presentation, Dr. Trescot, and it's also good to see Professor Sudhir Diwan. And thank you, Dr. Yossi, for your wonderful webinars. Actually, my questions a few of the questions were answered about the choice of the injected and the concentration of dextrose. And I just want to ask, how do you decide upon the volume of injected? And second question, there are a lot of reports and studies using the platelet-rich plasma for hydrodissection of. What's your experience about it? Thank you.
I use enough volume to distend the tissues and not so much to cause an entrapment. So I'm looking very much like when I do an adhesiolysis, I'm trying to look for runoff so that I'm not getting loculated fluid. And if I start to see that it's not distending anymore, even though I'm putting in more fluid, I stop there. So the amount that I use is enough and not too much, but usually somewhere under, I know a lot of people use more. I don't usually use more than about 5 cc's for most situations. And then the second question was, and I've forgotten the second question. Oh my goodness, it's been a long day already.
About platelet-rich plasma injections for.
Oh, platelet-rich plasma, yeah. There's a platelet lysate. If you take those platelets and then you cause them to clot, and you take the lysate, the serum that's above the platelets, that has been used effectively. I have some problems with the red PRP, in other words, one that's got a lot of red blood cells in it, because I think you're just creating a terrible inflammatory reaction along a nerve that's already inflamed. However, if you're able to really get a nice, clear platelet concentration, the white PRP, then I think that might be a reasonable approach to working with the nerves. There's a lot of work being done looking at nerve growth factors and throwing in B12 and lots of things that are being used in the hydrodissection portion of it. And so I don't have easy access. The kits to be able to do PRP cost me about $150, and I'm usually doing this on people who can't afford a stimulator, or so it's not usually something that I'm doing. But there are lots of medicines that are being currently injected, and the platelet-rich plasma is one of them. The inflammatory portion of it bothers me a little bit, but the stem cells might make a lot of sense, but I don't think that there is going to be a lot. There's not a lot of evidence for that yet. Sudhir, you've done a lot more.
I think you're absolutely right, Andrea. The final product of PRP is very important. If you have little more RBCs and more WBCs, that doesn't really serve the purpose. You have to have minimum white cell count and no red cell counts. And I'm doing regenerative medicine at least last 5 years, and I have learned from using different systems that there are systems that will give you a red platelet, as Andrea says, which is plenty of RBCs, you don't need it. and there are systems that give you very clear yellow colored platelet plasma, and that's what I use. I have use of PRP for a lot of other areas, disc and spine and joints, very minimum for the peripheral neuropathy, and rather peripheral nerves where you find the pressure. Having said that, I have used in a few patients, they have done very well, but platelet doesn't last too long. They have to come for repeat and they have to pay out of pocket. So I kind of tend to jump to peripheral stimulator easily and sooner rather than, because that's paid by the insurance and at least patient doesn't have to pay out of their pocket.
Yeah, I have to agree. There was also a comment about how PRP is better than Prolo. And I've worked with both of them now for a lot of years. Prolotherapy is my treatment of choice because it's cheap. And I can use a very large area. So I literally see patients that I inject from the back of their head down to their tailbone, or I'll do multiple joints. So my preference is to lay down the tissue with the prolotherapy. If there are areas that are not responding to the prolotherapy, a smaller area, then I'll use PRP there. I'll do PRP for small joints. I'll do PRP for a knee or a hip, and a small area of the spine, but it is much more expensive. And having had both prolotherapy and PRP on my hands, I will tell you it's intensely more uncomfortable. And I'm not convinced it gave any better or longer treatment than the prolotherapy that I had 10 years of relief from prolotherapy, and the PRP has given me about a year. I'm starting to get some crepitance. It's going to be time to do something again soon. So they are tools, and which is better, a hammer or a screwdriver? Well, it just depends on what it is you're trying to do.
The intention is, yeah, that's very true. Prolotherapy causes healing by causing the inflammation, and PRP will give you some more proteins, especially depending on where you are injecting. There is one component that we are not paying attention to is alpha-2 macroglobulin, which is a broad spectrum protease inhibitor that prevents the breakdown of cartilage. So wherever there is cartilage, I always like to use H2M. So there are different reasons, and as Andrea said, more sophisticated products you are looking for, it will be more expensive. For example, if you are looking for H2M, just the concentration system will cost you $600, and the product itself will cost you extra $1,500. So it's not that easy to really decide, because all this money are coming from patient pockets. So you have to be very mindful of what are they spending for and how much benefit they are going to get for a long time.
Prof, alpha-2 macroglobulin mostly in the poor PRP, right? In the PPP.
So it's actually a whole new discussion, but very briefly, when you do a PRP, you get it platelet-rich plasma from the buffy cord. And the solution that is above buffy cord is called PPP, platelet poor plasma. That is the plasma which is 90% water and 10% protein, and that 10% protein is made of macroglobulin and all the scaffolding protein, which is fibrinogen, fibronectin, like that.
For separating the alpha-2 macroglobulin from the PPP, we can only using the filter or something like that, or we can do the just like PRP centrifuge technique or something like that, Professor?
No, that's not based on the gravitational forces. It's all mixed with the water, so you have to use the filter, and that's why they call it concentrating system, which is made of three syringes. One syringe has a PPP that you push it through the filter to another syringe, and the water drops down to the third syringe, which is a very simple system. But because it is time consuming, and the system itself will cost you more money. So what I'll do is, depending on where I'm going to inject, If I have a shoulder or knee or a hip joint, which are very large area, I just use more PPP without concentrating it, and it's not a downside. The only thing you are doing is taking more extra water, which is not the end of the world, but that will save $1,500 to your patient. Yeah.
That's right. That's right. Okay. Okay. So for the next question from Dr. Redwan. Hello, Doctor. Hi, Doctor. Dr. Redwan from Dr. Redwan Mekarnia. Hi, Doctor. Hello. No, not. Hi, Doctor. Okay, okay.
Again, Linda,
Dr.
make
Redwan.
sure that microphone is not off.
Like the microphone is off.
Yes, the microphone is still off.
Yeah. But I think Linda may have to unmute it. Okay, good. Yeah.
Okay. Still cannot see the picture
Yeah,
of Dr. Redwan.
I think you should read the question, Dr. Yossi.
Okay, I will read the question from Dr. Redwan. Sorry, this one. Okay. He asks about what your approach for abdominal wall nerve entrapment syndrome. I think it's
so. First, making the diagnosis, then the hydrodissection. I saw a question there about the tap block. The tap block is working at the nerve entrapment on the other side. It's after the nerve has passed through the fascia and you're putting local anesthetic in the rectus sheath. And so that's like numbing up the finger if the problem is the carpal tunnel. And so I try and trace the nerve. I try and look at the nerve. I try and make sure that they're not more entrapments more posteriorly, like that external oblique. Make sure it's not a foraminal narrowing that's also causing a problem. But I'll do the diagnostic injection. I bring them back for a hydrodissection, and then I either do I usually do cryoneuroablation at that point.
Okay. I think the last question is from Dr. Franciscus Budianto. Hello, Doctor. Dr. Franciscus.
Hello.
Hello. Hello, Doctor. You can ask your question directly.
Hello. Thank you, Dr. Joshi. And good evening, Professor and doctors. But my English, my speaking is not good. Would you
better than mine, I'm afraid.
would you read my question only, please?
Okay.
How effective is the nerve block for the nerve suralis and the nerve tibialis and to reduce neuropathy of the median and lateral tarsal? And what's the right procedure to do that nerve block? So again, it depends on what the entrapment is. So if I have a patient, here's the foot, and they had an inversion injury to the foot, this is going to be the superficial peroneal nerve. If they had an eversion to the foot, it's going to be a problem with the saphenous or the posterior tibial, because posterior tibial is going to be here. And so you can treat them proximally at the knee or even at the sciatic nerve, but that's not where the pathology is. So I try and examine them. I do believe that you can do a great deal of good with peripheral neuropathies. Even though we think of peripheral neuropathies as affecting all the nerves, almost always there's one nerve that started first. And that's where that's the main actor. And if you can get that one under control, the rest of them will do much better. So I always ask, where did the pain start first? If it started on the big toe, it's a superficial saphenous. If it started across the top of the foot, it's going to be a superficial peroneal. If it started at the ball of the foot or the tips of the toes, then I'm looking at the tarsal tunnel. If it started on the heel, I'm looking at the sural nerve. And so based on that, that's where I start with my diagnostic injections and my therapy. And it just always surprises me how much relief you can get. It's almost like getting rid of the ringleader of a mob. If you can get him under control, then the mob just sort of dissipates. And so finding that place that was the original major pain, because remember that with peripheral neuropathy, most of these patients have numbness. It's only some of them that have pain, and it's that pain that causes them to see you. We can't do a lot about the numbness, though I play around a little bit with hydrodissection of the nerves, a little D5 of the nerves around the foot for numbness of peripheral neuropathy. But clearly what I'm focusing on is the pain. And so if you can relieve the main pain, then the rest of them, the medicines can usually get under control. And so I'll usually just focus on one. And so the tibialis and the sural, well, here's a great example. The sural nerve gets, with thrombophlebitis, gets trapped between the heads of the gastrocnemius. And so they'll have this persistent pain after a deep venous thrombosis. And everybody says it's thrombophlebitis that's causing the pain. But in my experience, it's the sural nerve that's causing the pain. So again, you got to be a big hero, get them off their anticoagulants and fix the underlying problem, because the inflammation from the thrombophlebitis originally triggered then the neuritis from the nerve that's traveling with it. And so you treated the thrombophlebitis, but you never treated the neuritis.
Okay.
Did that help answer your question, sir?
It's okay. Thank you, Dr. Trescot.
Yeah, so when you say the right procedure to do that nerve block, in my mind, it depends on where the pathology is. So you can do the sural at the lateral ankle, just posterior to the lateral malleolus. And that is for things like Achilles tendonitis. That's a good place they had an Achilles inflammation, and then that triggered the nerve pain and the persistent pain. They won't be actually tender over the Achilles, and the ultrasound of the Achilles will look perfectly normal, but it'll be a sural problem. The sural could be a problem in between the heads of the gastroc. And so how you treat it depends on where the pathology is, just to use that as an example. Okay.
Okay. Thank you.
Thank you, Dr. Franz. Okay, so the time is up. So many questions, but the time is up. So thank you again, Dr. Trescot, for a wonderful and very fantastic presentation. Thank you, Prof. Sudhir, as a panelist, and Dr. Carol here helped me about the disease discussion. I hope you guys can join again for our next webinar. Our next webinar will be with Dr. Chi Peng Lin from Taiwan, and also George from US. You guys know Dr. George, I think, right? So I hope you guys can join us again. I will send the link to you guys, so you can all join us and we can have a great discussion for the webinar. Okay, thank you again, Dr. Trescot, Dr. Carol, and Prof. Sudhir. Okay.
Thank you. Yep.
Thank you so much. Thank you.
Thank you. Okay, so for the participant, our next webinar will be with Dr. Chi Peng Lin from Taiwan, and also Dr. George Changdu from the United States. So I hope you guys all can join us for our next YAP Talk series after for the next month. Thank you so much for all your participation. Thank you again for all the panelists and the speaker. Thank you.
Thank you very much. Yes. Thank you, Carolina. Good to see you.
Bye.
Yeah, bye-bye.
Bye-bye. Yeah.
Carol, send my regards to Pedro.
Thank you for the excellent sharing and tips, Dr. Trescot. And of course, thank you to the moderator, Dr. Yossi. It is very wonderful and insightful presentation for everyone. Before we leave, we would like to encourage all of the participants to participate in our polling or feedback of today's session. Right now, in the screen in front of you, there is a polling to fill in right now. And thank you for those who have submitted the polls. And for the next episode of Interventional Pain Update, we will have digital dialogue on September 5th with Dr. Chi Peng Lin from Taiwan and Dr. George from America. And don't forget to register and join our next episode. The link is in the chat section. And stay tuned for any update in Dr. Yossi Instagram and Pain Institute Indonesia YouTube. Once again, thank you very much to all of participants for joining in, and thank you for our speaker, Dr. Trescot, and moderator, Dr. Yossi. And also thank you to crew organizing team behind the scene. Today's event is brought to you by Pain Institute of Indonesia and supporting organizer by Esculap Academy, a B. Brown company. So stay tuned for the next episode and we will see you. Goodbye.